This is Randall Schell, and I'm making a podcast entitled High Yield Keyword Review Specific Organ-Based Clinical and Respiratory System. It's a two-part podcast. This is part one of two. Dr. Bowe presented other topics on respiratory physiology, and this will add to that. If we look at the respiratory keywords from 2015, we'll go over several of these. Cricothyroid muscle innervation. Notice there's a B next to it. That stands for basic exam. An A stands for the advanced exam. Cricothyroid muscle innervation. It's innervated by the superior laryngeal nerve, which is basically a branch of the vagus nerve. The recurrent laryngeal nerve supplies all the other muscles of the larynx. Alveolar gas equation, knowing how to calculate it when you go up to altitude, how you hyperventilate in response to hypoxia. ARDS in ventilator settings, understanding volume trauma and pressure trauma and how low tidal volume breaths and keeping plateau pressures down is important. Geriatrics and pulmonary changes, how their closing capacity goes up, that is, their small airways are closing at higher tidal volumes, their FRC goes up, they have more compliant lungs. One lung ventilation and hypoxemia, if it's severe, you should go back on two lung ventilation. Otherwise, we'll go through the steps of managing hypoxemia during one lung ventilation. Smoking cessation, acute, how nicotine effects are gone very rapidly, carboxyhemoglobin levels improve, and oxygen content goes up over a period of hours to day, while months are required for return of pulmonary function test improvement of, for example, F2575, ciliary function, etc. Subglottic drainage, we put endotracheal tubes with subglottic drainage in an attempt to decrease the incidence of ventilator-associated pneumonia, VAP. So patients are going to be intubated for an extended period of time. For example, with ARDS, a subglottic drainage endotracheal tube can be used. SpO2 and carbon monoxide. Carbon monoxide absorbs very similar to oxygen, and your SpO2 monitor will not detect it, while carboxy levels can be detected when you draw an arterial blood gas and run it through a co-oximeter. Respiratory quotient refers to CO2 evolved versus oxygen used in the different nutrients that your body uses, such as carbohydrates, proteins, and lipids, with carbohydrates producing the most CO2 by oxidation. However, the flip side of it is if you overfeed someone in the ICU with TPN, for example, and they start to, instead of oxidizing nutrients, are mainly making lipids, for example, lipogenesis, the respiratory quotient can be greater than 1. Things that increase FRC, such as aging, PEEP, another example, and the emphysematous patient. Mainstem intubation, the physiologic effects, hypoxemia, peak airway pressures, etc. Oxyhemoglobin dissociation curve, the things that shift it to the right and left. Right being the classic things like acidosis, increased temperature, 2,3 DPG increase. The things that help unload oxygen to the tissues is a right shift. Pulmonary diffusing capacity, we measure DLCO. We'll talk a little bit about DLCO. Reflex bronchoconstriction and what controls it. One of the major determinants is the parasympathetic nervous system has a lot of control, and blocking that during airway manipulation is important to prevent bronchoconstriction. Aspiration management with an LMA in place, head down, suctioning, removing LMA, intubating a patient, suctioning the endotracheal tube, not instilling water or bicarbonate, not giving antibiotics or steroids. Those are some of the principles of management. And some indications for hyperbaric oxygen, like carbon monoxide poisoning would be an example. So let's look at the gaps in knowledge now, which is the topics that more than 50% of the residents in the United States, CA3 residents that is, missed. And one was hypercapnia following administration of oxygen to a patient with COPD. Used to teach many years ago that if you gave oxygen to a patient with COPD, their CO2 would rise because they already have a blunted CO2 drive, and if you give them oxygen, then they don't have hypoxic drive, and their CO2 will rise. And so be very careful, we used to say, about giving oxygen to a patient with COPD. The mechanism of hypercapnia is actually when you give oxygen, the oxygen in the lung dilates the blood vessels of the lung that are normally constricted by HPV, and blood can go to places where it shouldn't go, which is a VQ mismatch, and result in hypercapnia. Lipogenesis, or formation of lipids, is associated with a higher respiratory quotient than 1, which is carbohydrate metabolism, 0.8, which is protein metabolism, and 0.7, which is lipid metabolism. And then when you draw an arterial blood gas and you talk about strong ion deficit, that is the difference between the cations and the anions, which we will talk about, the fact that dehydration, which increases the sodium in a patient, so you lose free water, sodium goes up, cations go up, you can get a contraction, alkalosis, and an increase in the strong ion difference. Some other key words I'm just going to go through very quickly. You can stop the podcast if you like and look at these, but these are going back many years, all the way back to 2007, of keywords that were asked on respiratory topics. And we will start right in on our main topic with the first one being airway innervation. The 5th, 9th, and 10th cranial nerves are involved in airway innervation. In the bottom right, you can see blue representing the trigeminal nerve, or 5th cranial nerve, the nasopharynx. Yellow representing 9, the glossopharyngeal nerve, supplying the tongue, the oropharynx, and the upper part of the epiglottis and the gag reflex. And then the reddish pinkish color being the distribution of the vagus nerve. But the vagus nerve has two major divisions when we're talking about the airway, and that is the superior laryngeal nerve and the recurrent laryngeal nerve. The superior laryngeal nerve has two branches, the internal and external branch, and up at the top right shows the internal branch piercing the thyrohyoid membrane and going internally, supplying the mucosa sensory above the vocal cords, as opposed to the external branch of the superior laryngeal nerve, which supplies motor to the cricothyroid, the one muscle supplied by the superior laryngeal nerve. All other muscles of the airway are supplied by the recurrent laryngeal nerve. We can block the superior laryngeal nerve at the thyrohyoid membrane bilaterally. Now, the recurrent laryngeal nerve is sensory below the glottic opening and is motor to all of the muscles except the cricothyroid. It can be blocked by injecting a local anesthetic through the trachea, transcricothyroid injection, and as you cough, as the local anesthetic goes up and down the trachea, it anesthetizes this distribution below the vocal cords, that is the recurrent laryngeal nerve. The recurrent laryngeal nerve can be damaged and it can be cut in totally separated and transected. If it's unilateral, you tend to get voice changes and hoarseness, but if it's bilateral, you can get into real obstruction and problems. If it's a partial injury, such as someone takes a forceps and squeezes it on both sides and damages it but doesn't totally transect it, the cords can end up actually bilateral adducted and together and cause an acute obstruction requiring tracheostomy. If they're completely transected, the vocal cords tend to sit in a paramedian position towards the midline, but flap as the air passes it, and do not cause complete obstruction. So it's actually worse to have a partial injury to the bilateral recurrent laryngeal nerve. Airway anesthesia, we can block the superior laryngeal nerve, we can block the glossopharyngeal nerve, and we can block the distribution of the recurrent laryngeal nerve. At the top left shows an internal and an external block of the superior laryngeal nerve. Remember, that is a division of the vagus, 10th cranial nerve. The internal block can be performed by taking a gauze soaked in local anesthetic and holding it back behind the tongue. This is like looking from behind and out the mouth of a patient. And that forceps is coming in, holding the gauze with local anesthetic, letting it sit next to the epiglottis and the base of the tongue in the piriform recess area, and that will block spirolaryngeal nerve. We rarely do that. An external block of the spirolaryngeal nerve can be done bilaterally at the thyrohyoid membrane. So here's the thyrohyoid membrane between the thyroid cartilage and the hyoid cartilage, and here's the nerve piercing it. And you have to do it bilaterally, and it's fairly painful, or can be fairly painful, and again, that is not done very commonly. That would block spirolaryngeal nerve, which is sensory above the vocal cords. And remember that the 9th cranial nerve supplies part of the epiglottis, and the 10th cranial nerve supplies the lower part of the epiglottis. Glossopharyngeal nerve is represented, that block that is represented here in the top right. And you see if you pull the tongue over the base of the tonsillar pillar, inject here, you can block the gag reflex. Again, not a block that's done regularly. If you want to block the distribution of the recurrent laryngeal nerve, you can take a needle, inject it local anesthetic through the cricothyroid membrane. It stimulates a cough, which spreads the local anesthetic up and down the trachea, resulting in sensory block of the distribution of the recurrent laryngeal nerve, which is the trachea. Recurrent laryngeal nerve, remember, also supplies all the muscles of the larynx except the cricothyroid. When you do airway anesthesia, you need to make sure the airway is dry first, or the local anesthetic is not going to work very well. There's many options. You can use a med neb, in which if a patient breathes deeply, the whole airway can be anesthetized. You can spray and go with local anesthetics like benzocaine and lidocaine. Remember that local anesthetic spray to the trachea results in quite high local anesthetic levels in the blood, and if you spray a lot, you can get into problems with local anesthetic toxicity, even seizures. And with benzocaine, methemoglobinemia is a specific risk where your saturation begins to head towards 85%. Patient can turn a bluish color, and the specific treatment for it is oxygen and methylene blue. You can also do blocks of the 9th, 10th cranial nerves, but spray and go is one of the most common. Innervation of the airways. The parasympathetics have rich innervation of the bronchi and bronchioles, as opposed to the sympathetics, which the innervation is sparser, and circulating catecholamines from the adrenal, for example, or exogenous administered catecholamines are what have a major effect, as opposed to direct innervation. Going back to the parasympathetics, remember that acetylcholine acts on muscarinic receptors, resulting in bronchoconstriction of the conducting airways. Ipratropium is an inhaled anticholinergic agent, and therefore effective in blocking parasympathetic-induced bronchoconstriction. Beta-adrenergic receptors can be activated and result in bronchodilation, and they can be activated by inhaled albuterol, for example, intravenous epinephrine, or inhaled epinephrine. There are other methods of bronchodilation or bronchoconstriction, and there's systems that control that. The non-adrenergic, non-cholinergic system is one. For example, vasoactive intestinal peptide causes bronchodilation, and things like tachykinins and substance P cause bronchoconstriction. In the histamine system, we normally think of, for example, during anaphylaxis, when histamine goes up, as bronchoconstrictors. And histamines do, via the H1 receptor, cause bronchoconstriction. That's the predominant effect of histamine. But histamine also can stimulate the H2 receptor, which causes bronchodilation. And therefore, the question of giving a H2 blocker to an asthmatic patient, maybe that might not be the best idea, because you can actually precipitate asthma symptoms. Comparing albuterol versus ipratropium, albuterol is an inhaled beta-2 agonist, and it is used for acute treatment of bronchospasm. It relaxes smooth muscle. And remember, catecholamines also inhibit chemical mediator release. That's why we use epinephrine for anaphylaxis, for example. The duration of action is about 4 hours and can relieve symptoms for up to 8 hours. But if you use albuterol regularly, you can get tolerant to it. It's why we don't use these short-acting beta-2 agonists around the clock in patients with asthma because of this tolerance, and then when they need it in an emergent situation, it doesn't work very well. Beta receptor downregulation is one mechanism. Some side effects of albuterol: 1, tachycardia, and 2, it drives potassium into the cell, the beta effect, and hypokalemia is 1. Ipratropium is an inhaled anticholinergic drug that causes antagonism to acetylcholine, and it works very effectively to bronchodilate in patients with emphysema and chronic bronchitis. And it has a slower onset than does albuterol, lasts a little bit longer, doesn't have a real effect on heart rate or intraocular pressure, which you might worry about with blocking anticholinergic effects. And it's very good at treating bronchospasm that is reflexively associated with tracheal instrumentation. Tracheal instrumentation bronchoconstriction is predominantly muscarinic mediated because of the parasympathetic predominance of the lung innervation, and intravenous glycopyrrolate or inhaled ipratropium can block that. Next topic is control of breathing. Your brain and the peripheral chemoreceptor carotid bodies are two major mechanisms of control of breathing. Your brain, specifically the medulla, responds to changes in pH that result when CO2 crosses the blood-brain barrier, changes the hydrogen ion concentrations, which then has its effect on the medulla of stimulating respiration in the case of CO2 rising. The question that was missed frequently in 2015 was related to giving supplemental oxygen to COPD patients. What happens and why can CO2 rise when you give them oxygen? And the major mechanism is VQ mismatch, because oxygen actually decreases hypoxic pulmonary vasoconstriction or vasoconstricted pulmonary arteries in areas of the lung that should have constricted blood flow. When you give oxygen, it can dilate those arteries, and blood can go to areas that are not ventilated well, i.e. VQ mismatch, and CO2 rises. The peripheral chemoreceptors, carotid body specifically, responds to the tension of oxygen, that is pLaO2. Do not confuse this with saturation or content. It is tension. And the patient who has, for example, carbon monoxide poisoning, where content is reduced, but tension may be okay, may not see a hyperventilation state in a carbon monoxide poisoned patient. When hypoxia occurs and the peripheral chemoreceptors sense that pLaO2 decrease, respiratory rate and tidal volume will increase. What happens though when we go up to higher altitudes where the ambient oxygen levels are less? The patient will, and you will, increase your minute ventilation. Respiratory rate and tidal volume will go up. Because the carotid body senses the reduction in pLaO2 in your body, because you're breathing a lower ambient oxygen, and you'll start to hyperventilate. And as you hyperventilate, this will increase the alveolar oxygen in your lung and drop the CO2, and you get a respiratory alkalosis. And over time, you start to compensate for that, the respiratory alkalosis, by urinating bicarbonate. And by giving Diamox, you can accelerate this compensatory process that is developing. And so for patients who are going up to altitude, we can give prophylactic acetazolamide. I personally have taken this when bicycling over mountain passes in Colorado. Diamox, what it does is inhibits carbonic anhydrase, and carbonic anhydrase catalyzes the reaction shown here, and excretion of bicarbonate occurs in the kidney. If you lose bicarbonate, that acidifies the blood and a metabolic acidosis occurs. This shifts the oxyhemoglobin curve to the right, which increases delivery of oxygen, increases PaO2. and helps you compensate for the reduced ambient oxygen that's present at altitude. The decreased alveolar oxygen that you breathe in results in the arteries next to those alveoli constricting. That's hypoxic pulmonary vasoconstriction. And if you have global decrease in oxygen that you inhale, your arteries in both of your pulmonary, in your both lungs will constrict, pulmonary hypertension can occur, and right heart failure. And another thing that can occur at altitude is high altitude pulmonary edema from capillary leak. So at altitude, your minute ventilation goes up and your P big AO2 goes down, and you can get pulmonary hypertension. CO2 response curve is the next topic. The response to CO2 is linear between about 20 to 80 millimeters of mercury CO2. And the graphic at the top shows on the y-axis alveolar ventilation in liters per minute versus PaCO2. And if you look at the awake normal state here, you can see that as the CO2 goes up in the body, there's a linear increase in alveolar ventilation. As you introduce opioids and inhaled anesthetics, you can see that there's a movement of this curve to the right and depression of the slope, such that as CO2 goes up, you do not ventilate as much. Apneic threshold is increased by inhaled anesthetics and opioids, and there is a relationship between hyperventilation and hypoxia, such that if you have a patient who has a rise in CO2 who's simultaneously hypoxemic, so combination of hypercarbia and hypoxemia, they will ventilate even more than they would if they were not hypoxemic. The next topic is hypoxic pulmonary vasoconstriction. One of the major points to realize is that the blood vessels surrounding the alveolus respond to the oxygen levels inside the alveolus itself, which is the P big AO2. This is not P little AO2, this is P big AO2. And as P big AO2 decreases in an alveolar segment or in the whole lung, the artery supplying that alveolar segment or whole lung vasoconstricts in an attempt to shunt the blood to better oxygenated alveoli. This is the mechanism in an attempt to reduce shunt, for example, with one lung ventilation. If you're ventilating the right lung only, the left lung is not being ventilated, the alveolar oxygen levels in that left lung go down, and the blood vessels going past it constrict to shunt the blood over to the lung that is being ventilated on the right. And if you have hypoxic conditions such as occur at high altitude, and you get HPV going on in your pulmonary artery throughout your lung, you can see how this can result in pulmonary hypertension and right heart failure. Some of the things that we do inhibit hypoxic pulmonary vasoconstriction, and our inhaled anesthetics do so, but clinically have not a big effect on oxygenation, but inhaled anesthetics, we can measure an inhibition of hypoxic pulmonary vasoconstriction as opposed to intravenous anesthetics like propofol, which have little effect on HPV. Some people who are doing one lung ventilation, who are having problems with oxygenation, who are providing general anesthetic with an inhaled volatile anesthetic, may switch to a TIVA-based anesthetic in an attempt to improve oxygenation by stopping the inhibition of HPV that occurred with the inhaled anesthetics. Systemic vasodilators, if we turn on nitroglycerin or nitroprusside, the pulmonary arteries in our lung have a set point, an optimal set point. And when they've set optimally to the P big AO2 that is present in the alveolus that they're supplying, and then you give a vasodilator, the vasodilator can change that set point, vasodilate that pulmonary artery to that alveolar unit, and provide blood to units that shouldn't have it. And you can see a decrease in P little AO2 when you turn on nitroglycerin or nitroprusside. So what is the mechanism of decrease in oxygen levels in the blood, PaO2, with turning on vasodilators? The answer is inhibition of HPV, but another mechanism can be also if the patient gets hypotensive, you increase zone 1 of the lung, where P big A, or the pressure in the alveolus, exceeds the arterial pressure, little a. Now the lung not only has respiratory function, but also metabolic functions. You probably remember that the lung is important in activating angiotensin 1 to the potent vasoconstrictor angiotensin 2, and ACE inhibitors inhibit that conversion. The lung is performing that conversion, so it activates some substrates. But it inactivates many other substances, vasoactive. For example, serotonin is almost completely removed. Norepinephrine, a large amount of it is removed. But epi, it has very little effect on. The lung manufactures surfactant. Prostaglandins are removed from the circulation, but also synthesized when you stretch the lung. Prostaglandins can be released. Maybe that's one of the mechanisms of inflammation with volutrauma. The fibrinolytic system lyses clots. For example, if you have a pulmonary embolus, the lung can start fibrinolysis and lyse the clot in the pulmonary vessels. A question for you now. Which airway nerve block would increase the risk of pulmonary aspiration of regurgitated gastric contents the most? So if you have regurgitated gastric contents in the back of your throat and you've numbed up the trachea by injecting local anesthetic transcricothyroid, it spreads up and down the trachea, distribution of the recurrent laryngeal nerve is numbed up. You can imagine how acid fluid from your stomach could go down all the way and way out into the lung without you even coughing. So think twice about anesthetizing the recurrent laryngeal nerve in a patient who has a full stomach, for example. Now some oxygenation equations. Alveolar gas equation is the most important. Dr. Bowe touched on some of these, but we will go over it now. Alveolar gas equation is the way you calculate the P big AO2, or what the alveolar oxygen levels in millimeters of mercury should be. So PaO2 is calculated based upon your FiO2 times your atmospheric pressure, which at 1 atmosphere is 760, minus water vapor pressure, which at normal temperature of the body, 37 degrees, is equal to 47 millimeters of mercury. So 760 minus 47 leaves you with approximately 710, FiO2 times 710, if you're at 37 degrees and 1 atmosphere. And then you subtract out the effect from CO2, a gas that's also present in the alveolus, and that's PaCO2 over respiratory quotient. And respiratory quotient refers to the ratio of carbon dioxide evolved to that of oxygen consumed when you're using different nutrients. And when you're using carbohydrates predominantly as your power source to your body, the ratio of CO2 evolved to that of oxygen consumed is 1 to 1. That is, C6 carbohydrate would go to 6 CO2 molecules, as opposed to proteins, which the RQ ratio is 0.8, and lipids, the least amount of CO2 evolved for oxygen used. And therefore, if you have a patient in the ICU, for example, who you're having a hard time getting off a ventilator, weaning, and they're on TPN, you may reduce the amount of carbohydrates in their TPN solution and attempt to reduce the amount of CO2 that is evolved and required to be expired, which would increase the work of breathing. So lipids may be more of the predominant power source or energy source to that patient. AA gradient is calculated using the alveolar gas equation to calculate the big A, and then an arterial blood gas to obtain the little a. And when you're breathing room air, that should be less than 20 millimeters of mercury, AA gradient. And if you're breathing 100% oxygen and your AA gradient is greater than 350, this is an indicator of acute respiratory failure. You can also use the ratio of little a over A, or PF ratio is another thing that you can use to monitor oxygenation. And little a, big A is a monitor of shunt and compensates for changes in FiO2, and the ratio of P little AO2 over PaO2 should be greater than 0.75. Oxygen delivery versus oxygen use. Delivery of oxygen to the tissues is the amount of blood that goes to the tissue times the amount of oxygen that's in the blood that goes to that tissue, which is content. So cardiac output times content is oxygen delivery. And you should be able to calculate content, which is your saturation times the amount of hemoglobin, grams per deciliter, times 1.36 mils of oxygen per gram of deciliter hemoglobin. That's the amount of oxygen bound to hemoglobin, plus the amount that is dissolved, which contributes very little to content under most circumstances, but is p-LiLaO2 times 0.003. Under hyperbaric oxygen conditions, dissolved can make up a larger component of content. But usually hemoglobin is the biggest actor in content calculation. Oxygen use can be calculated by the amount of blood that goes to the body and the difference in content between what's in the artery and what comes back in the venous system. And 1 MET, or 1 metabolic equivalent, is equal to 250 mils of oxygen a minute, that classic amount that each of us use when totally still and only using basal amounts of oxygen. 4 metabolic equivalents, equivalent to be able to climb a couple flights of stairs, for example, would be 4 times 250 or 1,000 mils of oxygen a minute. Oxygen dissociation curve is the next topic and some of the factors that affect it. The graphic shows the things that shift it to the left and the things that shift it to the right. As you shift it to the right, there's reduced affinity of oxygen for hemoglobin and better release of oxygen to the tissues. As you shift it to the left, there is a better grabbing on of hemoglobin to oxygen, greater affinity. Things that shift it to the right include higher temperature, acidosis, higher 2,3-DPG levels. Things that shifted to the left, just the opposite, hypothermia, low 2,3-DPG, which can occur in blood that is old and been sitting in the blood bank with low 2,3-DPG levels. It's not going to release oxygen to the tissues as well. And alkalosis and carbon monoxide can shift the curve to the left. So tissue pH, the release of oxygen to the tissues is favored by a lower pH, a right shift of the oxyhemoglobin dissociation curve. Now, things that shifted to the left versus things that shifted to the right, left shift, carbon monoxide, fetal hemoglobin has a P50 of approximately 18 to 20. This is good because it wants to grab onto oxygen from the mother who has a little bit above normal P50s, so she wants to release it to the fetus. Normal being 27, pregnancy a little bit increased, and sickle cell and other hemoglobinopathies can have actually a right shift of the oxyhemoglobin curve above a P50 of 27. Now when you get hypoxic, what happens? What are some of the physiologic effects? Remember that a saturation of 90% is approximately a PO2 of 60, and a normal oxyhemoglobin dissociation curve would have a P50 of 27 millimeters of mercury. In the lungs with hypoxia, in the alveolus, if it gets hypoxic, the arteries going past it constrict and pulmonary artery pressure will go up. Pulmonary vasoconstriction due to HPV. In the brain, as you get hypoxic, it will stimulate hyperventilation. And interestingly, oxygen has very little effect on cerebral blood flow until the p-LiLaO2 gets down into a very low level, approximately 50. Remember that brain blood flow is mainly dependent on CO2 levels, and with oxygen having very little effect until you get very low. So if you have a patient who is a trauma patient who, for example, has a lung contusion, is not oxygenating well at all, and a head injury combined, you've got to get their oxygen level up if you're going to try to get their CO2 down in an attempt to maintain their intracranial pressure, because very low oxygen levels result in a great increase in cerebral blood flow. In the cardiovascular system, as you get hypoxic, there's a reflex increase in heart rate, blood pressure, and cardiac output because of catecholamine release. But that's initially. As profound hypoxia occurs for an extended period of time, blood pressure will decrease, vasodilation will occur, and bradycardia will occur. Remember that adults tend to respond to hypoxia with an increased heart rate, at least initially. Infants are different. When infants get hypoxic, they become bradycardia. So if you see bradycardia when you're managing an infant, think hypoxia first, second, and third. CO2 transport. How is CO2 transported in our blood? Mainly as bicarbonate. The graphic at the right shows CO2 leaving the peripheral tissues, goes into the RBC, carbonic anhydrase catalyzes it, and to bicarbonate. And that's the major mechanism. It can also combine with proteins, carbamyl hemoglobin, when it combines with hemoglobin, and some of it can be dissolved in solution. But number one is bicarbonate. There's something called the Haldane and Bohr effect, which facilitates CO2 transport. Specifically, if you think of Haldane effect occurring at the tissues, when the blood comes to the tissues have a lower oxygen tension than does the blood. Therefore, there's a gradient for oxygen to go from the blood to the tissues. As there's a release of oxygen to the tissues, the hemoglobin, when it doesn't have oxygen bound to it, this facilitates the binding of CO2. And that's called the Haldane effect at the tissue level. And then when the blood comes to the lung, and CO2 is higher in the blood than it is in the alveolus of the lung, there's a gradient for CO2 to go from the blood into the alveolus. And as CO2 is released from the hemoglobin and goes into the alveolus at the lung, this actually facilitates oxygen binding, and that's called the Bohr effect. We talked about acute hypoxia, now about acute hypercarbia. When your CO2 goes up above 45, what are some of the effects? Well, first of all, it is caused by either inadequate ventilation or increased production of CO2. Examples of inadequate ventilation would be CNS depression from pharmacologic means, for example, neuromuscular depression, where you have partial paralysis, rebreathing because of expiratory or inspiratory limb valve malfunctions or CO2 absorber malfunction, and then increased production, exogenous CO2 coming from a laparoscope procedure, for example, TPN carbohydrates. If you're giving lots of carbohydrates in the TPN, remember the RQ ratio is 1 and lots of CO2 produced. When you give an amp of bicarb and watch your end-tidal CO2, your end-tidal CO2 rises as carbon dioxide is produced from the bicarbonate. And then when you release a tourniquet, such as in orthopedic surgery, you will see CO2 rise, increased production. The perioperative signs of acute hypercarbia include vasodilation with flushed skin because of the catecholamine release. There's cardiac dysrhythmias, hypertension, and tachycardia. And when you see a patient in the recovery room who's retaining CO2, it's not uncommon to see them with hypertension, tachycardia, and sweating, and decreased mentation. Some organ effects in the central nervous system. CO2 increases, and as it increases cerebral blood flow. The major control of cerebral blood flow is CO2. Now, if you get very high CO2 levels, it can cause a comatose state, and there's no change in MAC, though, with a pCO2 in the normal ranges of 20 to 100. Cardiovascular system, as CO2 goes up, it activates the sympathetic nervous system. Catecholamines go up, and initially you'll get an increase in blood pressure and cardiac output, but if you get very massive hypercarbia, the end result can be just the opposite, a decrease in cardiac output, blood pressure, and heart rate. But initially, hypertension and tachycardia with elevations in CO2. In the respiratory system, the pulmonary vascular resistance goes up. There's a right shift of the oxyhemoglobin dissociation curve. And as mentioned, metabolically, norepinephrine, catecholamines go up and cause vasoconstriction and hypertension. As you get acidotic from the elevation in CO2, respiratory acidosis, remember that acidosis increases potassium levels as opposed to alkalosis, which decreases potassium levels. Low end-tidal CO2, if you have that occurring, look at your waveform as well as your absolute end-tidal CO2 value. If you have a sudden drop to 0 of your end-tidal CO2 or near 0, think that your endotracheal tube may be malpositioned, such as in the esophagus. You may have had a disconnection of your circuit, or if you have a full cardiac arrest with no blood coming back to the lung, CO2 can go away very rapidly. Abrupt decrease, such as going from 35 down to 15, that is something you'll frequently see when you have a thromboembolus, fat embolus, air embolus, amniotic fluid embolus, severe hypotension, low cardiac output, and hypoperfusion. As your dead space with hypotension, that is, as your blood pressure decreases, dead space goes up, and your end-tidal CO2 can drop. So a low blood pressure and a low cardiac output can result in increased zone 1 and a drop in end-tidal CO2. A gradual decrease can occur if a patient's just not making very much CO2, for example, hypothermia, or you just iatrogenically cause too much minute ventilation. You've turned up the tidal volume and or the respiratory rate, and it's more than what the patient needs. Here's a question for you. What is the result of bilateral carotid endarterectomy on ventilatory response to hypercarbia and hypoxia? Well, the carotid body is present at the site of the carotid endarterectomy, and it's denervated during a carotid endarterectomy. So your response to hypoxia is not present if you had a bilateral carotid endarterectomy. So C, a decreased minute ventilation in response to hypoxia. You would not hyperventilate in response to hypoxia if you've denervated the carotid body bilaterally. Let's talk about shunt versus dead space. Shunt is blood going to an area of the lung without ventilation. The classic example would be a main stem intubation. You put a patient who's doing fine in a head down position for laparoscopic surgery. They insufflate the abdomen, it pushes up on the diaphragm. In the head down position, the tube slides down the right main stem, and suddenly the peak airway pressures go up, the saturation drops, you have an increased AA difference, and the cause is a main stem intubation. The non-ventilated lung, which has a low P big AO2, is going to have hypoxic pulmonary vasoconstriction occur in an attempt to raise pulmonary vascular resistance in the side not being ventilated to shunt blood to the lung that is being ventilated. Normally, shunt is only about 3% of cardiac output, and that is through the bronchial, pleural, and Fabrician veins. If you have a patient who is not oxygenating very well and you start to increase the FiO2 and there's no change in their P-AO2 or very little change in their PaO2, think about intracardiac or intrapulmonary shunt as the cause. For example, I had a patient in the ICU one time who had 60% FiO2 on a ventilator after cardiac surgery, and they kept going up from 60 to 70 to 80 to 100% with little change in PaO2. And I said, there must be an intracardiac shunt. And someone said, well, they did a TE during the surgery. And I said, I'll bet you there is a patent foramen ovale and PFO. And we did an echo, and there was, with a big right to left shunt. And that was the cause of the lack of improvement in oxygenation as you increase FiO2. The shunt equation is shown here only for you to stare at in awe and think about at some other time and work it, and we're not going to cover it in great detail. Dead space is the next topic, which refers to ventilation without perfusion as opposed to shunt, which was perfusion without ventilation. This is classic zone 1 of the lung, where P big A is greater than P little a, so you have ventilation without perfusion. The normal dead space of our body anatomically is approximately 2 mils per kilogram, or 1 mil per pound, or approximately 150 mils to get air from our mouth down to the terminal bronchioles. The ratio of dead space to tidal volume is approximately 1/3. That is, dead space is 150, and if normal tidal volume is approximately 450, the ratio of 150 over 450 is 0.3. 1/3, or approximately 30%, goes to the plumbing just to get the ventilation down to and past the terminal bronchioles where air exchange begins. The Bohr equation can be used to calculate VD/VT, which uses P little a CO2 minus P expired CO2, which classically you had to collect CO2 from a patient into a bag and then measure it, that was the mean expired CO2, over PaCO2 to get that ratio of VD over VT. There are some things that affect VD over VT. Tracheostomy allows you to bypass the oral pharynx in the upper part of the trachea, so it actually reduces VD/VT, and that's why partly the reason why we perform tracheostomy in patients that are difficult to wean in the ICU. One, we need to be able to suction them, easier to wean, but also reduction in VD over VT. If you intubate someone, put an endotracheal tube down into their trachea, bypassing the oral pharynx, and allow them to continue to spontaneously breathe, this bypassing of the oral pharynx with the endotracheal tube actually reduces VD over VT. But if you start mechanical ventilation in that patient, positive pressure ventilation raises P big A, which raises zone 1 of the lung, which actually increases the VD over VT. So intubation with mechanical ventilation, VD over VT increases. And if you put a face mask on a patient, you're adding even more dead space. If the VD over VT is greater than 0.6 in an ICU patient, for example, this patient is not going to be able to wean, and you've got to do everything you can to reduce dead space. Factors increasing this VD over VT: as you age, it increases. Increased airway pressures because of zone 1 of the lung, and mechanical ventilation are examples. Dead space in the circle system itself, however, is only distal to the Y piece, assuming you have functioning inspiratory and expiratory valves. So taking the corrugated tubing of a circle system and extending it, or even putting 2 of them together to accommodate a patient that's farther from the machine, this does not increase dead space. If you put a humidivent, though, in the position that we normally put it, you can increase dead space. So dead space in a circle system, distal to the Y piece. Lung compliance, next topic. Compliance, by definition, is a change in volume over a change in pressure. That is, if you can get a bigger change in volume and a little change in pressure, that is a very compliant system. It can take up the volume without changing pressure. When we talk about compliance of the body, specifically the lung and chest, we need to think of both the thoracic cage and the lung itself. And the thoracic cage and lung compliance are added not in series but in parallel. So like resistors, when we add them in parallel, 1 over the total compliance is equal to 1 over the thoracic compliance versus 1 over the lung compliance. And this is classically normally 100 mils of gas for each centimeter of water is the total compliance of the system. On the graphic on the far right shows pressure versus time curve from ventilation, and you can see a peak airway pressure and a plateau airway pressure, and these will be important as we talk about dynamic and static compliance. These can be confusing at times. If you think of dynamic compliance as being calculated as a volume, the tidal volume, over a pressure, the peak pressure is what we use, minus PEEP if there's present. This represents what's going on in resistance to gas flow in the tubing, in the endotracheal tube, in the airways, in the chest wall, and classically, if it goes up, that's an obstruction of some type or bronchospasm of some type. So we use peak pressure in the denominator to calculate dynamic compliance, as opposed to static compliance, which we do a tidal volume over a pressure, tidal volume over plateau pressure in this case, minus PEEP, and this is a representative of what's going on, a representation that is what's going on in the lungs. Static compliance tells you about the lungs, so if they're stiff, the static compliance goes down. Acute respiratory failure, by definition, can be a problem with oxygenation, a problem with ventilation, and a problem with respiratory mechanics. Usually, if the PaO2 is less than 60 millimeters of mercury, breathing an FiO2 is 60%, or you have a large AA gradient, alveolar arterial gradient greater than 350, breathing 100% oxygen, we say that's hypoxic respiratory failure. If the CO2 is up in a patient greater than 50 who doesn't have COPD or VD/VT greater than 0.6, we say that's hypoventilation. And abnormal respiratory mechanics are things like tachypnea, a very low vital capacity, or inability to create a negative inspiratory force, a sucking force of -20 or more negative than that. Let's talk basics of interpreting an arterial blood gas. First point I want to bring out is when you draw a blood gas, what is measured and what is actually calculated. pH and the tensions of oxygen and CO2 are actually measured in the blood gas machine, while bicarbonate and base excess or deficit are calculated. When you look at your pH, which is a measured product, we will first determine, are they acidemic, less than 7.35, or alkalemic, greater than 7.45, and does PCO2, the change in it, represent the change that's occurring in the pH. For example, a change in CO2 of about 10 should make the pH units change about 0.08 to 0.1, i.e., if your CO2 went up 10, respiratory acidosis, your pH should go up approximately 0.08, so 7.4 to 7. Respiratory acidosis 7.32. And if that's true, that relationship is true, it's a simple respiratory disturbance, respiratory acidosis, respiratory alkalosis. If not, it is a mixed acid-base disorder. You can also look at, when you interpret your blood gas, a cause of hypoxemia. If your PaO2 is low, you can calculate your AA gradient. If it's normal, think of hypoventilation or decreased inspired oxygen as the cause. For example, high altitude. Or if the AA gradient is increased, think of shunt, VQ mismatch, or diffusion issues. There's a key word related to respiratory alkalosis and what can cause respiratory alkalosis. Well, anxiety, a patient breathing rapidly, stroke, subarachnoid hemorrhage, aspirin, stimulants of the sympathetic nervous system like doxapram, which aren't used anymore to any great extent, high altitude where the inspired FiO2 is low and the response of the carotid body is stimulation of hyperventilation, lung disease when you have a low PaO2 in your body, your carotid body senses it and you hyperventilate, fever, and pregnancy. Let's end our discussion of this part 1 with a discussion of anion gap and strong ion difference. When you draw a blood gas, you should calculate the anion gap from your blood gas and your electrolytes. Your anion gap is your cations minus your anions. And your major cations that are used in anion gap calculation are sodium and potassium. But potassium is so low, a small component of this, i.e. 4 versus sodium, which is 140, that we can throw out the potassium and just use sodium as the cation side, and on the anion side use chloride plus bicarbonate. And the sodium minus chloride plus bicarbonate, cations minus anions, gives you a value normally of about 8 to 16. Albumin is a major unmeasured anion, and if you have someone with severe hypoalbuminemia, it can mask in anion gap acidosis. For example, if you have a patient with lactic acidosis in the ICU, lactate should provide an anion gap, but if they had concomitant hypoalbuminemia, albumins of 2 for example, that can mask that acidosis as lactic acidosis is developing. So be aware of that. Compensation and for hypoalbuminemia in your anion gap. Some causes of metabolic acidosis. There is anion gap and normal anion gap acidosis. So when you determine that the patient has a metabolic acidosis, you calculate the anion gap, and if it's high, you say, aha, what's causing that? It could be lactate, it could be ketones, could be alcohol, rarely methanol, could be uremia, aspirin, etc. Normal anion gap, you don't have these organic acids hanging around in the blood, but you're losing bicarbonate usually. And one of the most common by far causes of metabolic acidosis is loss of bicarbonate in the stool in a patient with diarrhea. So diarrhea causes metabolic acidosis because of loss of bicarbonate, as opposed to, and we'll compare it to, NG suction of the stomach, which removes acid and chloride, and as it removes acid and chloride causes an alkalosis. So acidosis with diarrhea, alkalosis with NG suction. Another example of normal anion gap acidosis is renal tubular acidosis and diamox, where when you administer acetazolamide to a patient, they waste bicarbonate because of inhibition of carbonic anhydrase. As they waste bicarbonate, a metabolic acidosis on the blood gas is seen. In patients with glaucoma, patients who are taking a diamox for high altitude acclimatization can show this. Last topic, strong ion difference. Kind of a similar concept in the fact that it is cations minus anions, and in the strong ion difference you have sodium, potassium, calcium, and magnesium minus chloride plus lactate, and the difference between those two is approximately 40. And you can see the major cations in this graphic, sodium being the most important one, and the major anions with chloride being the most important anion. Now, clinically, when you have a patient who has an increase in an anion or a cation in their body, electrical neutrality has to be maintained. So, for example, if chloride went up in the body for some reason, an example is massive resuscitation with normal saline, where normal saline has sodium of 154 milliequivalents per liter and chloride 154 milliequivalents per liter. Well, that's way more chloride than our body normally has. So if you gave 10 liters, for example, of normal saline, you've given a lot of chloride, an anion. Your body says, I must maintain electrical neutrality. So if you have lots of anions around and have decreased the strong ion difference, because the anion side is increased, water dissociates to a hydrogen ion to provide positively charged hydrogen ion, which then creates the classic hyperchloremic metabolic acidosis that we see with high volume resuscitation, normal saline, for example, in trauma patients. Now, contraction alkalosis is something else we see clinically when we give lots of diuretics over periods of days. If you have a dehydrated patient, if they have an increased sodium frequently, hypernatremic, that's a cation. So as the cations go up, you're increasing the strong ion difference and have less dissociation of water to hydrogen ion, so less hydrogen ions around, so you actually get a dehydration contraction alkalosis. And then if you're losing chloride from aggressive NG suctioning, that's losing an anion. So if you lose an anion, you don't want as many hydrogen ion protons around, positively charged, so there's less dissociation of water. Hydrogen ion plus hydroxyl ion goes back to water, and you actually have less hydrogen ions, and you have increased strong ion difference with metabolic alkalosis because of the loss of HCl. This is something that you're going to have to think about and go over in your head, strong ion difference and anion gap, to make sure you understand. And this is end of part 1 of a 2-part series on respiratory physiology keywords. I hope you have a great day. Don't forget to review part 2, which will be following shortly.